Hey guys, I'm Vic. I was at Leeds last year and I'm now working upstairs in cardiology here at the LGI. It's pretty good fun being an F1. I'm going to talk to you today on renal failure. I'm going to focus mainly on acute kidney injury because that's the main thing that you will see as a junior doctor, and it's also, well, pretty much definitely going to come up in your exams. If we've got time at the end, I've got some slides on chronic kidney disease as well, and if not, then they'll be uploaded to the website for you to go through in your own time. Okay, so first of all, just back to basics. We can classify renal failure into acute or chronic causes, and then subsequently to that we can classify it on its etiology. So whether it's a pre-renal insult, which is often due to poor perfusion, whether it's an intrinsic problem with the actual kidney itself, or whether there's blockage of the outflow of the kidney that's causing back pressure and causing the kidney to fail in that way. So as I said, I'm going to talk mainly about AKI. It's really important. As you can see, it affects a large number of inpatients, and of those 20%, sort of 30% upwards will die. In 2009, it was demonstrated by a big national report that we don't care very well for patients who are in AKI, and I think that's probably because lots of the time it isn't recognised and isn't managed properly. And the costs that you can see there are actually more than skin, bone and breast cancer combined for the NHS a year. So I thought it might be quite helpful to use a case to sort of go through the lecture and to make you think a bit more. So I'll introduce you to her. She's a 63-year-old lady. She had an ST elevation MI 3 days ago, and as management for that underwent primary PCI. She's previously been told she's only got one functioning kidney. You don't particularly know any more history than that. When she comes in and has her procedure, her creatinine is 151. You then measure it 3 days later on the ward, and it's 290. So what can you see is going on already? Anyone? Okay, well, she's in acute kidney injury, and we'll go on to talk a bit more about how we classify that and how we define it now. So following the NC-POD report, NICE put out recommendations that we use a scoring system to define AKI. And any of the following 4 criteria will classify a patient as having AKI. So you can see it's either a rise in the serum creatinine or a decrease in urine output. And the decrease in urine output is meant to be for over 6 hours, but obviously if you've got a patient in front of you that's anuric and has been for sort of 2 or 3 hours, you're going to be worrying. And as I said before, we can classify renal failure into the 3 different types of etiology. So you can probably see from the slide that the main causes of pre-renal failure are hypoperfusion, and that's from a variety of different insults. It might be that someone's got severe burns, that they're septic, and on the other side it could be that they're very edematous, that they're in liver failure or in severe heart failure. And you also sort of need to have a quick glance at their drug chart, see if they've been started on any high-dose ACE inhibitors recently, or if you might have an orthopedic patient who's come in and been started on lots of NSAIDs to try and manage their pain, and that could also be the cause. Then think about things that could affect the kidney itself. These are less common causes of acute kidney injury, but they are something that you need to think about, particularly if someone's got a past medical history of any sort of vasculitities or any systemic diseases. And then, particularly for elderly people, elderly men especially, we want to think about the post-renal causes, so causes of obstruction. It could be prostate disease, it could be renal calculus if you have a patient who's presenting with pain in their loins, and it could be a blood clot. So if we go back to Our Lady, if we think about the causes of AKI, does anybody have any idea what sort of the most likely cause of her renal function going off would be? And is there anything sort of that you've got in front of you there that would suggest sort of one leading cause that could have caused it? If you think about the management that she's had, could be, yeah. But sort of what I was thinking about was the fact that she's undergone PCI, so she's had an angio. So she's had contrast injected, and that's one of the major nephrotoxic things that we need to think about, and that's why it's you're always asked on CT and MRI request forms for your patient's creatinine and their EGFR, because it is known that over 15% of patients who have contrast studies will develop AKI, whether they've got renal failure to start with or not. So when we think about symptoms of AKI, often we don't really see any. Often it's an incidental finding on their blood results, and it's sort of a mishmash of other symptoms that they've got. But if we sort of try and pick it out, their urine output will probably have decreased. They may not be passing urine at all if it's in a very severe stage. Because of the build-up of urea in the blood, they become sort of quite nauseous, may vomit, and if they've got severe build-up of urea and become uremic, they might be confused and can develop encephalopathy. In terms of signs to look for, your patient might be hypertensive, but then if it's a pre-renal cause, that can't be sort of taken for granted because they might be septic and they might be shocked. If it's a post-renal cause, you'd always need to examine for a palpable bladder, and remember that if that's painless in doing so, it's likely to be chronic retention. The first sign for dehydration, so pre-renal states, would be postural hypotension, so you look for a postural drop in the blood pressure, and over 20 millimeters of the systolic is significant. You're unlikely to see a pericardial friction rub. Hopefully you'd have noticed that something's going wrong before you get to that stage, but that can occur in acute uremia. And if you have a patient in front of you, sort of classic butterfly rash of SLE and their kidney functions going off, then it's probably likely to be a renal pathology. So what to do in terms of investigating AKI? Well, obviously you want to do some bloods. You want to take a full history and find out what's been going on. So have they been sort of vomiting or had lots of diarrhea? Are they really dehydrated? Have they been unwell and aseptic? Do they have any previous history of kidney injury? And have they had any recent contrast studies? When you examine them, you want to look for signs of, well, acute illness and acute sepsis, signs of dehydration, so look at their mucous membranes, and again, do they have a postural drop? Or they could, on the other hand, be fluid overloaded, as we said earlier, so you want to look at their JVP, see if they've got any sort of pedal edema, which could occur in heart failure. And again, remember to palpate for the bladder. On urinalysis, you want to do just a basic dip to start with. Is there any protein? If there's a lot of protein in the urine, it suggests that there's a renal cause. So patients with nephrotic syndrome produce a lot of protein through their kidneys. If there's blood present, then you need to think about whether it's a UTI or an ascending pyelonephritis, or whether it's in fact red cell cast that you're seeing and they've got glomerulonephritis, so damage to the kidneys themselves. And if you see blood in the urine or any sort of thing that you're worried about, you want to send it off for an MCNS. And on microscopy, you want to look for signs of red cell casts, or which would suggest acute tubular necrosis, which can occur when you give patients NSAIDs or when they have an ischemic hit on their kidneys and the kidneys themselves are damaged. In terms of bloods, obviously you want to check their usinase and do serial usinase. You want to find out what their baseline creatinine is and what their baseline EGFR is, and see how much of an insult they've had on their kidneys and how much you need to correct that. Because obviously if you've got a patient with a baseline creatinine of 120 odd already, you're not going to correct them back to normal. You want to also do a full blood count and a CRP to check for any signs of infection. If you're thinking that they do have a renal pathology and that you can't find any sort of obstruction causing it, and they're not dehydrated, they're not sort of hypoperfusing their kidneys, then you could think about things like doing an ESR, so that's a basic screen for vasculitis, a C anchor to look for vagueness, or an ANA to look for SLE. And they're sort of the weird tests that you do need to learn for your exams, because I remember they did ask us those on the MCQs and the EAMQs. You could also do anti-glomerular basement membrane antibodies. That's looking for Goodpasture syndrome. And if you're suspecting that, you might have a patient with hemoptysis who's coughing up blood, because those antibodies also attack the basement membrane of the lungs and also cause renal failure. you'd be asked to do an ultrasound by the renal team, or if you suspected obstruction was the cause, and then other radiology sort of as your clinical diagnosis suggests. So if you think they might have renal artery stenosis, so if you've got a patient with a very high blood pressure who's not perfusing their kidneys well, you'd want to do a renal MRA to look for any narrowing of the renal artery. You might also want to do a CT KUB if you think that they've got renal stones. But one of the most important and most accurate investigations of assessing their fluid balance and of assessing how well you're managing their AKI is to do a strict fluid balance. And for that you really need to catheterize your patient. So then in terms of management, obviously you need to treat the cause first. You need to give fluids and monitor the accurate fluid balance. If you've got someone in severe heart failure, it does become more difficult, as I've been learning on cardiology, and you sort of have to balance it off with a bit of diuretics. But in essence, your patient will be dry if they're in AKI, so you do need to chuck fluids at them. You also need to have a look at their drug chart again and stop any nephrotoxic agents, because you don't want to cause any further damage. So things like NSAIDs, ACE inhibitors, diuretics, metformin is one that's quite commonly missed, and gentamicin and vancomycin are aminoglycosides, so if they've been started on any recent high-dose antibiotics, you need to be careful. If things do get bad, you would need to filter your patient, but there are strict criteria that you need to achieve in order to do that, and you'd also need to involve the renal team for that. So if you've done sort of everything you think you can for your patient fluid-wise, try to treat any infection that's there, but they've still got refractory hyperkalemia, or they're still in severe metabolic acidosis, or they've presented to you with signs of uremia, so they're confused, they're encephalopathic, or they've got pericarditis, or if they're in severe pulmonary edema, then you think about filtering them. And that's continuous hemofiltration. It's normally done in an HD or an ICU setting, and very rarely on the wards. If you think that your patient might need to be filtered, or if you think that the pathology is from within the kidneys itself, then a renal team referral would definitely be warranted. And again, like with anything, when you're an F1, if you're worried about a patient and you don't think that you can manage it yourself, just call for your senior advice. They might shout at you sort of within the first 5 minutes that you call them, but in the longer term it's going to be helpful for both you and your patient and your consultant, because your patient hasn't died. So if we go back now to Our Lady, and I'll tell you some things about her, and then I want you to sort of tell me what you think you need to do about that. So firstly, she tells you that she is still passing water, but you can see that her creatinine has gone up, it's over doubled. So do you think that you can believe her, or would you need to do something else? Anyone? Okay, well, I'd catheterize her. Even if she doesn't seem acutely unwell, you need to know an accurate fluid balance, and it is an indication for catheterizing someone. It might be uncomfortable for a few days, but it's going to get her over sort of the worst of it. So secondly, you look at her drug chart, and because of her heart attack, she's been started on high-dose ramipril through the ACS management guidelines. Would you do anything about that? Yeah, exactly. So it's a nephrotoxic drug, so we want to stop it. We can restart it at a later date when her kidney function's improved. You also look at her drug chart, and she's on metformin because she's a diabetic. What could you do about that, do you think? Okay, so again, it's a nephrotoxic drug, so you'd want to stop it. You'd want to keep a close eye on her sugars. If she does become sort of severely hyperglycemic, you could think about starting a sliding scale just for the few days whilst her kidney function is improving, and then once she's sort of back to her baseline creatinine, we can restart the metformin. For a lot of patients, you won't need to start the sliding scale. Just keep an eye on their blood sugars and just be sensible about it. And then Also, lastly, you look at her bloods, and on her last bloods, her potassium is 6.3. So what do people think about that figure? Good. Okay, I've passed out some drug charts and some fluid charts. I think hyperkalemia is one of the ACT conditions, and it did come up in our exams. So what I'd like you to do is to prescribe the management that you'd give for a patient with hyperkalemia. And I'll give you a couple of minutes to do that. Don't worry about filling out all the demographics and stuff, just write the drugs down. Yeah. No, can you grab some from people in front of you? Sorry. Yeah. Have we finished? We'll go through it. So, the management of hyperkalemia is particularly important, especially sort of patients with acute kidney injury. They're not able to filter out the potassium as well as they should be, and often despite giving management, you won't be able to bring their potassium down as quickly as you would with a normal patient. On my first weekend on cardiology, sort of a couple of weeks ago, I actually had to send a patient to ICU because we gave him all of the treatment twice and nothing happened. So we had to send him to be filtered. So what you want to do when you find a patient who's got raised potassium is firstly do another ABG. Your ABG will always give you a measure of potassium, so you can get another quick verification. You also want to make sure you've done an ECG. Hyperkalemia can cause arrhythmia, and you can see from the picture there what you might see in a patient who's got hyperkalemia with ECG changes. It's probably a good picture to look at and to learn for your picture exam, because they do tend to like to ask questions about it. So hopefully this is what you guys have prescribed. firstly we want to prescribe 10 ml of 10% calcium gluconate IV. That's cardioprotective. It doesn't do anything to your potassium, but it stops the arrhythmias from happening. And hopefully you've either prescribed that on the front of your drug chart, on the once-only medications, or on the fluid chart. It doesn't really matter which. You also want to prescribe 50 ml of 50% glucose IV, and that has to go with 10 units of Act Rapid. So you'd put that on your fluid chart with the 10 units of Act Rapid in the additions box. And obviously give that to one of the nurses ASAP, and make sure that your patient's got a cannula in. You can also use salbutamol nebulizers, so that would be 5 milligram nebulizers. You can pretty much use them back to back, and it helps to drive the potassium back into the cells. But the main three things to do are the calcium gluconate, the 50 ml of 50% glucose, and the 10 units of Act Rapid. And you can actually find the 10 ml of calcium gluconate as a pre-filled syringe on all of the crash trolleys. So, move on. The complications of AKI are pulmonary edema, because you've got too much fluid in your body, but you're just not sort of able to put it into the right spaces. As we talked about hyperkalemia, uremia, as I've said, the symptoms of encephalopathy, and it can also cause pericarditis. In terms of pericarditis, on your ECG you see a classical saddle-shaped ST segment, so it kind of looks like a reverse Nike tick. And your patient will have metabolic acidosis. There's not really anything you can do about that apart from correct their AKI. So, as we said, there's a very high mortality rate, and an increased risk of patients developing problems with their kidneys down the line if they do develop AKI in hospital. And it's pretty obvious really that patients with a poorer prognosis are going to be those who are older, who have got problems with other organs, and those who are severely hypotensive or do have chronic renal failure as a background. So in summary, if you're suspecting AKI, or you're looking at some routine bloods and you see a shoot up in the creatinine, think about AKI. Also important on ward round to note whether your patient is passing water or not, because that can be one of the early signs. Your kidneys are able to auto-regulate, but only within a limited pressure range, and any variation outside that will cause a massive hit on the kidneys. As you probably know from your experience, pre-renal causes are most common for AKI, and we can prevent it if we manage our high-risk groups properly, and so that's why you're asked for the EGFR and the creatinine on your CT request forms, to sort of minimise the risk of giving those patients contrast and giving them an insult. That's why we also make sure we measure using these before we start ACE inhibitors and diuretics, and why it's important to monitor them post giving the first doses as well. And if you're not sure about the cause, call the renal team, because it's likely that it will be an intrarenal pathology. So I thought I'd go through a few questions with you now. If someone wants to put their hand up and answer it. So firstly, you've got a 60-year-old man who's been admitted to you with general deterioration. He's known to have heart failure. He regularly takes 10 ml of ramipril, which is a high dose, and again a high dose of frusemide, and he's also got gout, so he takes allopurinol in the evenings. Last week he went to his GP because he had a bit of a cough, and they gave him amoxicillin. When you see him, he's drowsy, he's dehydrated, he's got a low blood pressure, his heart rate's okay, and his respirate's rate's 25. You then see his bloods, and you can notice that his urine, his creatinine are quite high. So from these four, what do you think would be the most likely cause of the AKI? Does anyone want to sort of shout out? Yep, definitely. So, likely that number one, the ACE inhibitors are contributing, but he's had a general unwell. He's been generally unwell, so he's likely to be dehydrated. He's also had the high-dose ACE inhibitors at the same time, so it's likely to be multifactorial. And just remember, like in your MCQs, that one thing will probably jump out at you, but read all of them, because it's asking you for the most likely, not what is likely. Secondly, you see a 34-year-old woman who's admitted with a week's worth of breathlessness and hemoptysis. On a chest x-ray, she's got bilateral opacification, but it's patchy. She's got a normal full blood count and a normal CRP. And her U&Es, you see again that her creatinine is raised. When you go to see her, she's alert, maintaining her blood pressure, and the only thing to note is that she's got slightly low sats on air, and she's not known to have COPD. So which further test is likely to provide you with a diagnosis of what's wrong with this lady? Yeah, it is, yeah. So I talked about it earlier, so this is good pasture syndrome. It's where you get destruction of the basement membrane both in the kidneys and in the lungs, and it's associated with a rise in the anti-GBM antibody titer. It's one of sort of the rarer systemic causes that you might need to think about if you've sort of excluded everything else. Next, you're asked to see a 55-year-old man. He's being treated for ascending cholangitis, and yesterday, unfortunately, he underwent ERCP, but they failed to remove the stone from his common bile duct. When you go and see him, he is alert and talking to you. He's dropped his blood pressure, though. His heart rate's okay. His rest rate's quite high. His sats aren't great, and he isn't known to have COPD, and he's got a temperature. He weighs 70 kilos. He's got a nephrectomy scar on his left-hand side, and for the past 2 hours, his urine output's been 10 mils an hour. For treatment of his cholangitis, they've given him IV gentamicin. So firstly, would anyone like to say if they think this patient does have AKI? Yeah? Does anyone want to put forward an answer? Okay, I can hear some yeses. I'd probably say yes too, but you can't be sure at this point. If we go back to the criteria for defining AKI, it's 6 hours that he has to have a decreased urine output for. He probably is an AKI, but you haven't seen his bloods yet, so you can't definitely say. And secondly, does anyone know what a normal urine output is? Yep, so 0.5 mils per kilo per hour. So you can see from that his is significantly below that. You'd expect it to be sort of 35. And thirdly, how would you manage this patient? Imagine you're sort of in an OSCE station and you've been asked for your management plan. Can anyone put one forward? Anyone want to volunteer? Doesn't matter if you get it wrong, you probably won't. Yep, good. And so what would you do? Yep, it is. He's talking to you. Okay, so if you go through it in an ABC. Yep. Yep, so he's completing sentences, he's gasping a bit, but you reckon that's because he's in pain? Yep, so he's maintaining his sats, you can see they're 96%. Yep, yep, yep. Yep, so you want to check his pulse. His heart rate's 80, you can see. Yep, and do you want to do anything about that blood pressure? Yep, so what would you give him to start with? And how much of normal saline? Probably start with like a 500 ml fluid challenge first and see what that does. But that's good, yeah? Then anything else that you want to do. So you've gone through your ABC and you've sort of given him a fluid challenge, made sure that his heart rate and his sats are okay. What further things would you like to do? Yep, definitely. Yep. Yeah, good. So we want to stop his gentamicin. And also, sort of, it comes in C, but we talked about it a bit earlier. You'd want to catheterize him and look for his inaccurate urine output. Really good, well done. And then finally, a bit of a picture for you. So this picture is taken from urine MCNS of a patient who's been admitted not passing any urine. They recently had a sore throat and cold and flu symptoms. Can anyone tell me what the picture's of? Yep, so it's a red cell cast. And what would be your diagnosis for this patient? I think I heard it, but is anyone going to put their hand up and say? Yeah, good. So it's post-strep glomerulonephritis. And this picture actually came up in our picture exam. So they do show you some weird and wonderful things. So that's all I've got about acute kidney injury. Does anyone have any questions at all? No?
Brilliant. Well, thank you.
Interesting.
Save it first without self-interest.
How do I do it?
I just turn around the line, just hit escape, and it should